Hello and welcome to the Binding Site webinar titled Multiple Myeloma and AL Amyloidosis, a case-based approach to diagnosis, prognosis, and monitoring therapy. Our guest speaker today is Dr. Joseph McHale. Dr. McHale is a consultant hematologist at the Mayo Clinic in Scottsdale, Arizona. He specializes in plasma cell disorders, namely multiple myeloma, amyloidosis, and Waldenström macroglobulinemia. Dr. McHale is currently the principal investigator of many clinical trials, primarily in multiple myeloma. His clinical research interests also include pharmacoeconomics, communication skill, and supporting care in cancer. Dr. McHale did his medical school and internal medicine training at the University of Ottawa, Canada. He then did his hematology training at the University of Toronto, followed by a master's degree in education and a multiple myeloma fellowship at Princess Margaret Hospital. He was a staff physician at the Princess Margaret Hospital and Toronto General Hospital from 2004 until 2008 when he moved to Arizona to work at Mayo Clinic. Dr. McHale is an associate professor at the Medical College of Medicine, at the Mayo College of Medicine, and is heavily involved in education. He's the Vice Chair of Education for the Division of Hematology Oncology and is the Program Director of the Hematology Oncology Fellowship Training Program at Mayo Clinic, Arizona. Dr. McHale is also the Vice Chair of the Graduate Education Committee. Dr. McHale, I will now turn it over to you.
Well, thank you very much, and welcome everyone. Thank you for that kind introduction. I probably should have just said my name is Joe and I'm here to give the talk, but we appreciate all the kind words. Let's move right into the talk. Hopefully all of you can see the webinar clearly on your computer screens. One of the things Frenak mentioned was that I did a master's in education. I always like to introduce objectives, each with a different verb when we give a talk. So what I'd like to achieve in the next 45 minutes or so is to, first of all, discuss the importance of accurate diagnosis in plasma cell disorders. As I'll describe in a moment, unfortunately, this is a complicated set of disorders that often are frankly misdiagnosed or perhaps diagnosed later in the course than could have been. And we want to make sure that we try and clarify some things that will assist in that diagnosis. And then secondly, we'll describe the laboratory rationale for prognosis. We've come to learn a lot more about these diseases of late, in particular what are prognostic features of the disease, and we'll emphasize some of those. Thirdly, I'd like to outline a very practical strategy to optimally monitor patients with plasma cell dyscrasias. So whether you're a clinician that cares for these patients or you're involved in the lab, this is a central piece of what we do to ensure patients are followed appropriately on and off therapy. And then in doing so, I'd like to review the clinical spectrum of plasma cell disorders. These are not simple diseases, and there are various aspects to monoclonal gammopathies and myeloma and amyloid that really what I often call have a spectrum from a very asymptomatic to a very dramatic presentation. And understanding that spectrum will be helpful in interpreting the laboratory investigations appropriately to make sure that patients are cared for when needed to be and often not cared for, meaning at least not treated when they don't have to be. So my disclosures, I have received an honorarium for this, but if I can call it my professional/personal disclosure, I see a lot of misdiagnoses and often, frankly, mismonitored patients with plasma cell, that should be dyscrasias, not plasma cell disclosures, my apologies. And it concerns me greatly that I have many patients that come to see me whose, in fact, ironically, it happened this very morning. I had a patient who has AL amyloidosis, and the physician out of state who was caring for my patient only wanted to follow their proteinuria and didn't recognize the significance of following the patient's light chains in their serum. And so I see a lot of that, and so I have a bit of a passion, even independent of this webinar, to try and assist both clinicians and those involved in the lab to better accurately not only diagnose but manage and monitor patients. And I created a slide set myself, so I'll take responsibility for any errors. So just as a quick background, I like this slide because it just gives us a little bit of perspective. Not that I suggest that anyone still uses rhubarb or orange peel to treat patients, but this is a quick history of the last 150 years or so of the care of patients with multiple myeloma in particular, really more broadly plasma cell dyscrasias. The bottom half of the slide focuses on therapies culminating in perhaps the three most important agents we currently have for plasma cell dyscrasias, thalidomide, bortezomib, and lenalidomide. But furthermore, if you look on the top half of the slide, that is more focused on accurate diagnosis and prognostic significance. So it wasn't until 39 that we were able to appropriately identify M spikes, but then considerably later, and now, of course, much more available at our disposal are the ability to look for light chain types, both kappa and lambda, not only to know that they're there theoretically, but be able to monitor them. And then more recently, there have been a series of staging systems, including the ISS and cytogenetic classifications that we'll talk about as we go through. So how do I want to achieve this? Because I really don't want to turn this into a boring didactic talk where I just show you one data set after the other. I'd like to build it in the context of 4 cases. So I'll build 4 sequential cases that will illustrate 4 different, I think, important aspects of the management of these patients. The first will be in a patient who has monoclonal gammopathy of undetermined significance, or MGUS, and that risk of progressing into a genuine plasma cell dyscrasia that requires treatment. Secondly, the appropriate and accurate diagnosis of myeloma. Thirdly, myeloma and the monitoring of a patient when they are relapsing, and asking an age-old but yet a very important question of when do we treat and when do we not treat. And the fourth case, I'd like to think a little bit with you about AL amyloidosis, both in diagnosis and response to therapy, and how we make sure we do so accurately. And then hopefully as we go through, I'll drop a pearl here or there, a couple of things that can help you both in your clinical and lab work. So the first case is a 58-year-old gentleman. This is a very typical case. I see many of these. This is from a real case that I had seen, who was referred by his primary care physician to the neurologist for evaluation of a peripheral neuropathy. Past medical history included diabetes, which you could probably immediately connect to the neuropathy, hypertension, gout with uric acid, as you see. And because this neurologist has a sort of required formal order set whenever a patient's referred for peripheral neuropathy, the patient had a serum protein electrophoresis done. And that indeed showed an M spike, low level, only 0.3 grams per deciliter, of type IgA kappa. The quantitative immunoglobulins, that is to say IgG, IgA, and IgM, were normal. The patient had a normal CBC. And the neurologist had concluded that the neuropathy was most likely due to the diabetes, but because of this so-called incidentaloma finding of an MGUS, now they're sent to you for workup of that M spike. And so you appropriately complete the workup. I'm leading the witness here, Your Honor, but telling you what you would have done, I hope, anticipate, that you would look for biochemical things. So their electrolytes, their calcium, their creatinine, albumin, and beta-2 microglobulin, and all of those are normal. And then you do the immunoglobulin serum-free light chain assay, which demonstrates a free kappa level at 13.5, which is elevated, a normal upper limit between 2 and 3, and the lambda level in the normal range of 1.2, resulting in an elevated and abnormal ratio of 11.2. You also performed a skeletal survey, which was normal, and because the patient had a normal CBC, because the patient had no bone disease and no evidence so-called of end organ damage, you opt not to perform a bone marrow aspirate and biopsy, which frankly I think is very appropriate in this case. So the family physician calls you in the interim saying, well, what do I do with this patient? Is this just an MGUS? What do I tell the patient? Do I need to do more tests? What is the patient's prognosis? And do they need therapy? And these are the questions that would naturally come out of an MGUS case. So we'll come back to those questions in the case in a moment, but let's step back for a moment and just get a little very quick picture of the spectrum, as I call it, of myeloma, a bit of a balcony view of myeloma in particular. And I think of these as, if you will, in 4 classes or 4 groups: monoclonal gammopathy of undetermined significance, what we'll just call MGUS from now on; asymptomatic myeloma, I like to say this is the artist formerly known as smoldering myeloma; true, genuine, if you will, multiple myeloma; and then perhaps we could add a more aggressive category of myeloma we often call plasma cell leukemia. By definition, in MGUS, one does not have organ damage. If a bone marrow is done, they have less than 10% plasma cells, and generally we manage these patients by seeing them 1 to 2 times annually, knowing that their risk, and I'll talk a bit about more for this in a moment, their risk of transformation to myeloma or its related conditions, and I always think it's important to add that rider of and its related conditions, because it's not only myeloma we worry about with MGUS, but more of that in a moment, is approximately 1% per year. And that's why we don't follow them as aggressively. By contrast, the really only difference between MGUS and asymptomatic or smoldering myeloma is that if a marrow were to be done, the patient would have greater than 10% plasma cells, which formally puts them in the category of myeloma. And as a result, we know their risk is significantly higher, almost 10 times higher, and we tend to follow them a little bit more closely. But similarly, they do not have the classic end organ damage, what's often called CRAB, elevated calcium, renal insufficiency, anemia, and bone disease. True myeloma does have some element of CRAB and has greater than 10% plasma cells, and so those patients do need to be treated. And then plasma cell leukemia, if you will, is just a greater and more aggressive variant of myeloma, where there's not only 10% plasma cells in the marrow, they actually escape into the peripheral blood, and this sadly carries a significantly poorer prognosis and often requires more intense aggressive therapy. So to summarize then, MGUS, someone has a monoclonal spike almost always less than or equal to 3 grams per deciliter, less than 10% plasma cells, without evidence of CRAB. And they're generally, if you will, speaking, asymptomatic. One exception to that rule might be neuropathy, which our patient has, and we'll come back to. And similarly, patients can't have any of these diseases. I'm not going to read them all to you. You can have this, of course, as reference, but these are diseases that we know can be associated with a monoclonal gammopathy. And so it is incumbent on someone when an MGUS is diagnosed to even consider these diseases in their differential to ensure we don't have to, in inordinate detail, do extensive testing to exclude every single one of them, but they should be at least on the clinician's mind. When we've looked back over the last 30 years or so here at Mayo, and we've seen nearly 40,000 patients with monoclonal gammopathies, you can see that MGUS is by far the most common, accounting for nearly 60%, and then another 20% with myeloma, and the rest are, as you can see, combination of diseases such as amyloid, lymphoproliferative diseases, and even Waldenstrom's macroglobulinemia. Furthermore, the type matches what would be expected, that roughly 2/3 are IgG, 17% IgM, 13% IgA, and the rest are a little less common, such as IgD or IgE. So for those of you joining us today from the lab, this is a beautiful piece of art for you, because you see these every day, either that or you're sick of seeing them. And you can describe this in much more detail than I can. But of course, the term M spike comes from this picture of a serum protein electrophoresis, whereby we see clearly here in the gamma region an M spike, which when further tested in immunoelectrophoresis, we can identify this patient clearly as having an IgG lambda monoclonal protein by virtue of the predominance of lambda over kappa. Furthermore, in evaluating immunoglobulins, it's not just a question of the quantitative M spike, but of their light chains. And so you remember here on our left is just an ugly picture of a bone marrow with some pretty hideous-looking plasma cells. But on the right is the immunoglobulin, where we see both the heavy and the light chains, their significance of which I'll explain in just a moment. So what leads to MGUS and ultimately myeloma is a whole other separate pathophysiological discussion, but I always think it's nice to put one slide in there to remind people of the complexity of this condition, that we still, frankly, don't know what should be on the bottom line here, but we do know that there are a lot of things that ultimately can transform a normal plasma cell into aggressive myeloma. This sort of follows the model of a multi-hit concept, where it's not likely one cytogenetic or one pathological event that leads to myeloma, but likely many, which is perhaps why this condition is significantly more common in the older population, that it takes time for all these things to occur. But we do know that there can be multiple things, such as whether it be translocations or infections or specific chromosomal deletions, such as the poorly prognostic P53 deletion, that can ultimately lead to myeloma and indeed aggressive multiple myeloma. So the risk of transforming from MGUS to myeloma and its related conditions is roughly 1% per year, which is considerably higher than the general population. We know much of this work because of the great work of Dr. Robert Kyle at the Mayo Clinic in Rochester, but this has now been confirmed in multiple countries, in multiple continents, frankly, with a similar result. What's interesting here is this is a continuous variable, meaning it's not like some diseases where if someone gets past that 4 or 5 year window, their risk goes down. When it comes to MGUS, that risk is a continuous variable. And in fact, now we have pretty good evidence that it's quite likely that everybody with myeloma has had a preceding MGUS. This is the sentinel work that goes back to 1960 through 94 that Dr. Kyle did, where they followed thousands of patients for whom they had had 1,300 in this study, whom they had had serum samples in Minnesota. And we see that by far the most common disease that MGUS transformed into was myeloma, but we can't forget the others, and that's why I always say unrelated conditions. We can't forget things like lymphoproliferative diseases, amyloidosis, and even Waldenstrom's macroglobulinemia. Well, going back to our case, what do I tell this patient? If there's such a variable risk, how do I classify that? And we actually now have some very strong and predictive and prognostic markers to guide the care of a patient like this. Over the years, multiple things have been demonstrated to be very important in determining someone's risk of going from MGUS to myeloma-related conditions. The size of the M spike, the type of the M spike, bone marrow plasmacytosis, the presence of Bence-Jones proteinuria, and most recently and importantly, the free light chain assay. These have been combined together. If you're napping, this is the slide you want to look at. I think this is particularly important, and I actually show this to all of my MGUS patients and teach this to my students and residents almost on a daily basis. 3 risk factors were combined in this model. The risk factors of having an M spike that's greater than 1.5, being non-IgG type, and having an abnormal light chain ratio. So if someone can have either 0, 1, 2, or 3 of those factors. And if someone has none of those factors, as evidenced in the bottom line here, their 20-year risk of transforming out of MGUS is only 5%. By contrast, the patient who has all 3, their risk factor is now 60%. That's quite dramatic. You know, if I'm seeing a 40-year-old patient with MGUS, or even a 50 or 60-year-old patient with MGUS, there's a huge difference between having a 5% risk over 20 years and a 60% risk over 20 years, and that might influence how frequently they're monitored. So our patient had 2 risk factors. You remember his was IgA kappa. It was only 0.3 grams per deciliter, but he did have an abnormal free light chain ratio. So if I go back up to the previous slide, he would be on this. He would be on this line where there are 2 risk factors. So he would be at that roughly 37%, or to keep it simple, 40% risk over 20 years, or 2% per year. So that's going to mean he's going to be regularly monitored, and things that we know while he's being monitored that are going to be predictive is if we start to see changes. And classically, we see sequential changes. I often talk to patients about the 3-step process of progression. Step 1 is we see changes in that free light chain. That is clearly the most sensitive change, or the sensitive marker of change. So in his case, he had that predominant kappa light chain. I would be concerned if I started seeing his kappa go up from what was 11 to 12 or 14 or 18 or 20. That may change long before the M spike will change. Secondly, then we see the biochemical or the CBC change. Classically, the hemoglobin starts to drop or the creatinine starts to rise. And thirdly, then we see clinical manifestations, which is why we want to see these patients even when they're clinically well. I don't want to wait until they've gone so far down that line that they're particularly sick to be seen. So light chain first, followed by M spike, followed by biochemical changes, followed by clinical changes. So let's leave MGUS for now. There'll be time for questions at the end if people wish. Let's direct our attention now to myeloma and our second case. The second case involves a 62-year-old woman who has newly diagnosed multiple myeloma. Fairly classically, she presented with rib pain. She was found to have multiple fractures. At the time, she had an elevated creatinine of 2.2. She was anemic. And her serum protein electrophoresis, interestingly, and I don't take this as a rare case. This is not uncommon in my practice, and I have several hundred myeloma patients in my practice. Her serum protein electrophoresis actually only shows a low level of an IgG lambda M spike, meaning it's only 0.3 grams per deciliter. However, thankfully it was tested, she has a particularly elevated lambda light chain. So her lambda light chain is 662, and I remember this patient quite well. And I've given you the normal range there just to remind us that depending on the lab and where people do it, that there are two measures of that lambda light chain, that the normal range can either be 0.5 to 2.6, or in some labs we'll have it one logarithmic level higher, where the normal range will be roughly 5 to 20. So in this case, she is several hundred times above the normal range. Not surprisingly, her bone marrow confirms that she has 36% plasma cells, and her cytogenetic analysis on conventional cytogenetics was normal. However, on her FISH panel, she has the intermediate, if not high-risk feature of a translocation 414, which, as you may know, has been associated with the FGFR3 gene abnormality. Partly because of the renal insufficiency and partly because of her 414, I placed her on Cybor-D therapy, as you may be familiar with it. It's a combination of 3 agents, each given on a weekly basis: cyclophosphamide orally, bortezomib either IV or sub-Q. In this case, we gave it to her subcutaneously, and thirdly, oral dexamethasone. Of course, as a side note to the clinicians, whenever you're using bortezomib, I would always give the patient prophylaxis for herpes zoster by means of acyclovir. After one cycle, her M spike, as you recall, was only 0.3 to begin with, but it apparently seems to be barely moved at 0.2. However, her light chain, which had been 660, is now 340, and her creatinine had come down to 1.5. After 3 cycles, or 3 months of therapy, her M spike is again moved barely, but her light chain is now 35, which is greater than a 90% reduction in her light chain. And we're planning to go on to stem cell transplant after cycle 4. So when we care for our patients with myeloma, we'll step back from the case again for the moment and then move back into it. Again, this is a slide that's fairly basic, but just to remind people that generally speaking, we divide patients into transplant eligible and transplant ineligible. They get their initial therapy, and that's followed either by consolidation, which in the top category was generally speaking transplant, plus or minus maintenance therapy. The whole discussion of maintenance therapy is beyond the scope of this lecture, but I'm always willing to chime in. And then, of course, we treat people at time of relapse, and all the while we're caring for them in a supportive manner because we don't treat disease, we treat people. And I just give this slide as a quick background to know that thankfully on the bottom, in the old days, and I don't want to sound like I'm that old, a hematologist or myeloma doctor, but we used to have very few options. We used to use something called VAD, as many of you may know, vincristine, adriamycin, and dexamethasone. We had transplants, and we had very few options, perhaps thalidomide. Well, now it's very encouraging to see that at the top of the screen we have multiple options. I've only listed really some of them, and I've put in italics those that are not yet FDA approved but are being evaluated in clinical trials or even potentially at the FDA, such as carfilzomib. And we have multiple options to care for patients. And thankfully, as many of you on the phone would know, that this has resulted in a significant prolongation of overall survival in patients with myeloma. Frankly, and I don't want to be a commercial for Mayo or any other myeloma group, but there are very few conditions we can say in the last decade we've tripled the average survival. But we've been able to do that in myeloma. It's still a hideous disease, still, unfortunately, technically incurable, depending on how you define the word curable, but nonetheless, we've made great progress. And one of the things that has significantly impacted that survival, and this is sentinel work from my very good friend and colleague who I just saw down the hallway a few minutes ago, Dr. Rafael Fonseca, who presented this work now nearly a decade ago, hard to believe that, where there were those 3 high-risk features in the bottom left-hand corner of this slide, translocation 414, translocation 1416, and the 17p deletion, or the p53 deletion, if you will, conferring a significantly poorer prognosis in patients living roughly 2 years with the disease, whereas those who had good prognostic markers could live greater than 4, if not greater than 5 years, and this is a whole decade ago, so that's changed since then. As a result, we at Mayo have put together something called MSMART that you can look up on your own, but the bottom line here is I really can't think of myeloma as a single disease anymore. I think it is unfortunate if people say, this is how I treat myeloma, I treat all patients this way, this is my standard first-line therapy, this is my standard second-line therapy. With respect, that is oversimplifying an inordinately complex disease. And we have suggested a risk stratification or risk-adapted approach whereby patients who have standard or lower risk disease can potentially be treated a little less aggressively. By contrast, those who have very high-risk disease who tend to be, if you will, fast growers are those that we would want to take a more aggressive approach and perhaps use bortezomib for reasons of good evidence, even published this year. We've also included an intermediate risk, which our patient potentially could land in. But you see here that the majority of the decision of risk stratification lands in the lap of FISH analysis. I'm not here to explain to you how we do FISH, but just to tell you a little bit about the results. If, on the other hand, by conventional cytogenetics, someone has either deletion 13 or hypodiploidy, that could be a high-risk feature. And then there are multiple approaches now to gene expression profiling, which is again beyond the scope of this discussion, but I would suggest a very important one, especially in the coming few years, that there are multiple models used to define high risk that way. And just to give you some teeth to this, that in our Mayo experience here, roughly 60% of people land in the standard risk, and another 40, between 35 and 40% land in intermediate and high risk, and as a result, it has impacted their overall survival, as you see on the bottom, whereas in our hands, the highest risk patients still, unfortunately, have a median overall survival of only 3 years, whereas now we're at pushing a decade in those with standard risk disease. I don't plan to go through this in any detail. This is really more reference for you, but it's to further clinically demonstrate the significance of risk stratification, that whether patients are transplant eligible or ineligible, our treatment strategy will be different. Whereas in standard risk, as I mentioned, we generally would use either a lenalidomide or a bortezomib-containing regimen, whereas in highest risk patients, we may combine them together, knowing that their disease can escape much more quickly. Similarly, in transplant eligible, we're more prone to use more aggressive approaches in the high risk than those with standard risk. So we could consider our patient, remember our patient here with only a low-level M spike but a very elevated lambda light chain. In a sense, she has oligosecretory myeloma, and if you were to only evaluate her M spike, it would be really hard to follow this patient, frankly. But we need to remember that somewhere around 20 to 25% of patients will have light chain-only disease. And so that light chain is particularly important, not only diagnostically in her case, for us to fully know the extent of her light chain myeloma, but also her response. If you were just following her M spike and you said, well, she went from 0.3 to 0.2 to 0.1, I guess that's response and that's nice. But with all due respect to our lab, I'm not sure they can reproduce the difference between 0.2 and 0.1 on a regular basis, because these things are not exact sciences and it's a challenge in the lab. Whereas the light chain is particularly predictive, not only to responsive therapy, and this is the monitoring piece that we're going to have. This is the centerpiece. If I'm only allowed to test one thing in this patient as I treat her, obviously clinically I must follow her and I want to follow her creatinine and so on, but the best measure, if you will, of her tumor burden or of her disease is going to be that light chain. And in her case, I would suggest that it's quite likely that high burden of light chains is what damaged her kidney. Of course, we know that intact immunoglobulins can be toxic to the kidney as well, but exquisitely so the light chains, and the faster we can get them down, the more likely we are to get renal recovery. And thankfully, as you saw from the case, that her creatinine was starting to come down. Let's move to a third case now. We're right on time, so let's move on to a third case of a 54-year-old gentleman who has known myeloma. He has IgG kappa type. He was diagnosed 3 years ago and had standard risk. If anything, he had hyperdiploidy, which may or may not even be in the long term thought of as a more indolent form of myeloma. At the time, he was International Staging System 2, and his initial M spike was 4.7, so not at all like our previous patient, clearly able to follow M spike and potentially follow M spike alone, although I'm going to advocate here that comprehensively to get more information, we want to follow this patient's light chain as well, because at diagnosis it was significantly elevated at 42. Remember the normal range being up around 2 to 2.5. He was initially treated with lenalidomide and dexamethasone. He had been clinically well. He had not had renal insufficiency and was treated with those. After 4 cycles, he had achieved a partial remission, which is to say a 50% reduction in his tumor burden. Went on to an autologous stem cell transplant, after which he achieved a very good partial remission, which is to say a 90% reduction in his tumor burden. So when he was evaluated at day 100, for those of you involved in transplant, you know that we often talk about the so-called day 100 assessment being critical. That's where we see the biggest bang for the buck, as it were, of a transplant. And so we always want to know what is the status of a patient at day 100. That will dictate what we attribute to the transplant in terms of response. He was at 0.3. So if we go back to where he was here at 4.7, he has definitely achieved that VGPR. That is to say a 90% reduction. anything, if you will, under 0.5 would have been a VGPR, and there he is at 0.3. And at the time, I think appropriately, because he had had hyperdiploid disease, because he had achieved a VGPR, it was decided not to go on to maintenance therapy, but simply to monitor him expectantly. And indeed, he has been clinically well now for over 2 years, and his M spike has been bouncing around primarily between 0.3 and 0.4. I didn't give you the exact numbers, but his light chains had normalized, had nearly normalized after his stem cell transplant down to a level of about 4 to 6. But now as you see him a little past 2 years post-transplant, his M spike hasn't changed, but his light chain now is starting to inch up. It had been 4 to 6, and now we're at 10 over these last 3 months. So this leads me to talk, again, a step back for the case for a moment, leads me to talk a little bit about the importance of relapse in myeloma. You know, this is maybe a theoretical point and one that I'm happy to jump up on a soapbox and say, you know, now that this disease has become more chronic, now that people are living longer with this disease, I think it's important that we think of a patient in the long term. You know, not to be too blunt about it, but when patients we knew were only going to live for a couple of years, you're sort of willing to throw the book at them, as it were, to give them all the therapies you have available to try and give the disease the biggest kick, knowing that sadly the disease will wake up again soon thereafter and you'll run out of so-called bullets for the gun. Well, now I'm going to suggest that if we're looking at a longer-term strategy, we don't want to deprive the patients of good therapy, of course, but we want to make sure that, as I describe it to patients, it's not a game, but I not only want to play the best card for you, I want to play the card that lets me play others later. If you're a chess player, you know, you don't want to just try and kill any opponent. You want to strategically take down that other opponent, and so sometimes it's going to mean taking more conservative steps as you build to something that is a long-lasting approach, and that's what we want to do in myeloma. So when I treat someone, I want to look at that long-term strategy. I want to obviously do what's evidence-based. I want to do what's rational, and here perhaps more importantly, and if I can put in a commercial for listening to patients and being individualized, you know, I do not have a standard second-line therapy for myeloma. I will always argue that it depends. It depends on the patient and a whole series of factors, some of which I'll explain to you in just a moment. And so we want to take a strategy that chooses the best therapy for the patient at the best time. And I've tried to simplify this in giving talks to community physicians and to others in the care of patients with myeloma. I've developed, not that I am Dave Letterman, but I've developed this simple 10 questions to ask yourself when someone is relapsing. And I want you to think about these as we consider our patient who's now relapsing or getting close to relapse 2 years post-transplant. Question 1, do I really need to treat this patient? This is perhaps the most important question. Going back to our spectrum of MGUS to true myeloma, you know, if I know someone's walking down a one-way street, I'm not going to wait for them to fall off the edge before I treat them. But at the same time, sometimes people can relapse so slowly that I don't necessarily want to jump in right away. But there are things that will cause me to treat the patient right away. Do they have any evidence of CRAB? Again, elevated calcium, renal insufficiency, anemia, or bone disease. But then I look at that pace of the relapse, and I have to say this is particularly important. You know, again, it's not like I set this up purposely, but I just came from a conversation no more than 45 minutes ago with a patient who is much like the patient we're discussing. Her relapse is happening so slowly. She had her transplant 3.5 years ago, almost 4 years ago, and at about 3 years post-transplant, her M spike and light chain levels started to very slowly climb. And it's climbing ever so slowly. She is feeling extremely well. She just climbed one of our mountains here in Arizona a few weeks ago. She feels well. Her CBC is good. Her biochemistry is good. Technically, on paper, yes, her measures are going up in that range of 25% that we consider significant to consider relapse, or at least 25% confirmed. But I'm not eager to treat her. I don't want to wait until I have a huge burden of disease to treat again. But I'm pretty happy with the treatment I've given her for the last 9 months, which is nothing, which carries pretty good toxicities. I'm obviously being a bit sarcastic here, but, you know, above all, do no harm. And so there are some patients that don't need to be treated. But if I'm going to do that, it's because I'm watching the pace of the disease. By contrast, I had a patient last week who is only 1.5 years after transplant and is beginning to relapse and is relapsing much more quickly. The M spike hasn't been moving that much, but that light chain is starting to go up. That light chain is the trigger to me. It's the appetizer before the main dish, as it were. It's telling me that something is coming. And because it's going up more rapidly, even though the patient is still asymptomatic, even though the patient still has a normal CBC and biochemical profile, I'm much more prone to jump in and treat that patient compared to the one who's relapsing at a slow level. I'm not going to take this much time for all 10 questions because we'd be here till tomorrow, but here's the other questions to consider. Number one is, what did I use last time? The point here being is, did it work the last time? And if there's been a considerable period of time that's passed, you can often go back. We don't want to exclude options with patients. How well was it tolerated? Did someone say, look, doc, thanks for the treatment, I'm glad it worked, but I don't ever want to see that drug again, or I don't want to go through transplant again? That's a very important consideration. Of course, have I employed what I call the big three? I mean, these are the three central drugs that we have right now, thalidomide, bortezomib, and lenalidomide. Ironically, I often get sent patients to me where the note is, has exhausted all therapies, please consider for clinical trial. Of course, I'd always consider for clinical trial, no matter how many therapies someone has had. But I look at these patients often, someone hasn't given them thalidomide. Thalidomide is still a very active and relevant drug to us in myeloma. And even in patients who are lenalidomide refractory, there are some who will give a response to thalidomide and vice versa. Question 5, is salvage transplant an option? There have been a couple of studies. I had the privilege of publishing one earlier this year, and there's another one currently in press that is looking at when we can consider a second so-called salvage transplant. That is to say, someone gets transplanted, their disease progresses, is it worth transplanting them again? And the general rule is someone must have had at least 2 years of a disease-free interval, or 2 years of progression-free survival before considering that. And our patient, he's past that she's past that 2 years, so that would be a consideration if someone could potentially go back to a second transplant, which is usually why in younger patients, in particular in our experience at Mayo, anyone under the age of 65, we collect enough stem cells for 2 transplants. Question number 6, have I employed the so-called add-on agents? You know, I often tell patients we have 7 major drugs in myeloma, the big 3 that I've mentioned, 3 add-on agents, cyclophosphamide, dexamethasone, and Doxil, and then drug number 7, the oldest drug in myeloma, melphalan. So very often, someone may have been exposed to the big 3, but these other add-ons can make a big difference. In particular, we've been extensively using cyclophosphamide and dexamethasone. There have been issues, as many of you might know, with availability of Doxil, but it's still an active drug. Question 7, does risk stratification affect my choice? I showed to you earlier our M-SMART approach, which is to say if someone has higher-risk disease, we're more likely to give them more combinations for an extended period of time, less so with the standard risk. And then those patient factors that are so important, that really influence. That's why they say I don't have a standard second-line therapy. I always look at multiple factors. How quickly are they relapsing? What is their age, the cost, the convenience, so-called steroid status? Some people just never want to have steroids again. Question 9, should I consider multiple novel agent use? That is to say, combining things like Velcade and Revlimid or bortezomib and lenalidomide together. Should I consider doing that? We tend to save that for more aggressive relapses. And then finally, always, I want to encourage people to consider a clinical trial. I won't take much time on this, but I think this is important because we've just recently published this work. This is just a sort of a side note of interest for those who are treating patients with relapsed disease. This is a figure that illustrates something we've entitled clonal tides, which is to say a patient who at diagnosis, this is a single patient at diagnosis, as you can see on the left, had multiple clones that dictated their myeloma. And over the course of this unfortunate patient's lifespan, it seemed that they would be treated, the dominant clone would decrease, and then a different one would take their place. And we've called it clonal tides, where a different clone appears. And that might influence our thinking with time if we understand this better, to say, look, maybe this person progressed on drug X before, but we could go back to drug X if now a more drug-sensitive clone has appeared. So there's no simple way to determine the timing of initiating this patient's therapy, but the rise of the light chains is predictive of the relapse, even before the M spike has gone up or other labs or clinical, as I've said. So we also want to be aware that more advanced cases of change of disease can happen, although this is not common, that there are people who can, with time, become oligo or even non-secretory, where we don't want to just hang on exactly an M spike or even a light chain assay for that matter. But we have to look at the patient's full clinical picture and evaluate them as we go. Finally, our last case, so we have plenty of time for questions. is a case of AL amyloidosis, as I mentioned. And this is another case that I saw a few years ago, in fact. She's a 48-year-old female athlete. She was actually a marathon runner. I'm a bit biased to marathon runners. She has minimal past medical history. She had had a total abdominal hysterectomy and a carpal tunnel release. And she noticed over the span of about 3 months that her performance status went down. Now remember, this is someone who's very active. But she was evaluated by her family doctor. She had a normal CBC. Her biochemical profile was essentially normal, apart from being a bit hypoalbuminemic. And she did thankfully go on to have a 24-hour urine collection, which demonstrated 8,000 milligrams of albuminuria. So to give you a sense, you and I are allowed, most labs will put a normal range up to roughly 100 milligrams of albumin or protein in our urine. This woman has 8,000. And interestingly, her serum protein electrophoresis is normal, but she was evaluated by nephrology for this nephrotic syndrome and ended up having a kidney biopsy, which was consistent with AL amyloidosis because of Congo red positivity, which was then sent on to Rochester for mass spectroscopy, which confirmed the type that indeed it was AL, not AA or ATTR or any of the others. Her marrow shows 12% lambda-restricted plasma cells with normal cytogenetics and positive Congo red staining. Then she was sent for evaluation and found that she actually had a light chain assay abnormality. This was not initially done, and that's one of the points of this case, is that sometimes people miss the very thing that is perhaps going to be the most important to follow as we treat them. But her assay was considerably abnormal with the lambda light chain of 58. Just as a side note, for AL amyloidosis, the lambda predominance is in almost 75% of cases, whereas in myeloma it's the reverse, that 75% of myelomas are kappa predominant. Her other workup revealed that she had diastolic dysfunction on her echo with an interventricular septal diameter of 1.4 centimeters. For those who aren't familiar, this is larger than expected. It shouldn't be over 1.1. Her troponin was normal, but she had a dramatically elevated BNP, or B-natriuretic peptide, of 2,000. Her alkaline phosphatase was normal. She did not have any hepatomegaly. She did not have any GI, neuro, bleeding, or skin complaints, nor abnormalities on physical exam. So she was also actually commenced on weekly Cyborg-D. I had the privilege of recently publishing our work on this. And her lambda light chains normalized actually after just only 2 cycles of therapy. Her performance status improved. I mean, she wasn't back to running marathons again, but she did struggle a little bit with edema, most likely connected to her dexamethasone. And now she's asking, should I have a stem cell transplant? Well, quick review of amyloidosis. I don't want to take too long. I'd like to finish in the next 5 minutes or so. But this goes back to Virchow, who is highly revered in the hematology world, father of the Virchow's triad, who described this extracellular deposit, which, for those of you who are much more familiar than I, that under appropriate Congo red staining is positive, leading to this classic apple green birefringence on polarized microscopy. And it has this classic beta-pleated sheet configuration. I jokingly did medical grand rounds entitled Amyloidosis and the Internist, a match made between the sheets, to try and emphasize this beta-pleated sheet phenomenon. And of course, amyloidosis is a disease that has at least 30 different trigger proteins, but we're focused mostly on the AL amyloidosis. And although it's a disease that's suspected clinically, tissue is the issue. We absolutely must have pathological confirmation. Obviously, what's specific to the disease is the Congo red positivity. This is just a figure from a New England Journal review of this that demonstrates to you that there are multiple kinds of amyloidosis, ATTR. Obviously, light chain is the one that we're focusing in on today, and you can see it's figured here. The biopsy, as I mentioned, is critical. We do usually try and obtain it by fat aspirate, where the sensitivity is approximately 75%, a little less in the bone marrow, a little less also in a gingival biopsy, but often we look at the organ involved and get an organ-directed biopsy. In this case, obviously, it was a clinical one. And then subtyping becomes very important. Sometimes it's pretty obvious. I think this case is pretty obvious. Her light chain really pushes me to think that this is AL. We, by process here, always want to make sure it's confirmed by mass spectroscopy. It was a very unfortunate and sad New England Journal paper written over a decade ago now, demonstrating that there were cases of hereditary or ATTR amyloid who are misdiagnosed as AL amyloid and end up having a bone marrow transplant, when frankly they should have had a liver transplant. So there's a lot at stake here to making the accurate diagnosis. And although staining is helpful, sometimes it's not obvious. And for those of you who do this stain, you recognize that. It is a bit of a diagnostic dilemma because almost any organ, I have seen amyloid of, you name the organ in the body, I've seen it. The most common, of course, is kidney involvement with proteinuria, neuro involvement with neuropathy, cardiac involvement with diastolic dysfunction, or just, again, as I mentioned, incidentally on a monoclonal gammopathy. And so this misfolding disease, as we've listed here, is lambda predominant 75% of the time and can impact many organs, of which the major ones are the three on the left that we think most importantly about: the heart, the kidney, and the liver, which can cause significant dysfunction in each of these. And sadly, the heart one, as I've listed here, is what we most are concerned about in terms of sudden death. You know, early diagnosis is perhaps the most important, and I've listed here for your reference the things that are now particularly important in the organ-specific features, all of which are, of course, in the organ side of AL amyloid. I always think of amyloid as there's the hematological parameters and response to hematological treatments, such as light chain changes, but the organ involvement is just as critical, of course, and you see here how we can monitor heart, kidney, and liver involvement. So we need to clearly identify that monoclonal protein if we're considering that this is AL, still with pathological confirmation. Just as a side note, myeloma and AL amyloid are often confused. I like to draw a little Venn diagram with overlapping circles and say, look, people really have one or the other. Yes, you can technically have myeloma, but you meet criteria for amyloid by having some Congo red staining positivity, or vice versa. You can really be amyloid, but if you have more than 10% plasma cells and an M protein, you technically meet criteria for myeloma. Our patient here, for example, with 12% plasma cells technically meets that criteria. But really, at the end of the day, one is dominant. Someone has critical features of CRAB, whereas the amyloid patients are organ-mediated signs and symptoms, like in our patient where she's dramatically weak and is having edema. We've really focused on this, so I'm going to skip ahead out of these two slides and give you this algorithm that we've developed that was published at JCO, that once someone has suspected, we need to obtain that SPAP and a serum-free light chain measurement. If it's positive, then we go on to do a bone marrow, and we look for the organs involved. If they're involved, if we need to get more tissue, we could, but we look to organ assess the patient. If negative, then we have to start thinking more clearly, could this well be amyloid, and if so, what other tests can we do? Finally, I'll conclude with a couple of comments on treatment of amyloid and monitoring, and we'll open it up for questions. Generally speaking, if people are under the age of 70, we consider them for an autologous stem cell transplant. If they're not a candidate, or even if they are a candidate, we may initially treat them anyway with something like Cybordide because of the recent work we've published. But melphalan and dexamethasone or prednisone continues to be a standard. We often have clinical trials, and we do have other agents available, primarily thalidomide and lenalidomide, but many of us have published now that it is challenging to care for patients with thalidomide because it tends to be poorly tolerated. If people have particularly cardiac involvement, we may have to boost their pressure with florimapine and midodrine. We've identified certain things that are particularly poor prognosis for transplant, including an elevated troponin, syncope, a widened septum, low blood pressure, uncontrolled heart failure, and indeed if someone has dramatic heart failure when undergoing collection. So our patient had significant clinical improvement after 4 cycles of Cybordide. As I mentioned, due to her edema, we reduced her dexamethasone. She underwent a stem cell transplant without a lot of complications. Interestingly, you know, she still has 4,000 milligrams of protein in her urine, and frankly, that might be permanent. She might have glomerular damage that is, frankly, irreversible. And if you only looked at that, as in the case I mentioned, the patient I saw earlier today, where the outside physician was only looking at that urine, they might think that that person hasn't responded to therapy, but it could well be that those 4,000 will never go away. But it's that light chain that becomes important. Remember, normalized after 2 cycles, and that's what I'm going to be following in this patient. So in conclusion, the initial evaluation of a patient with MGUS requires the major risk factors for progression to be evaluated. Remember, M-spike type, M-spike size, and the free light chain assay. Complete evaluation of a patient with newly diagnosed myeloma includes consideration of patients with oligo, non-secretory, and light chain only disease. The free light chain assay facilitates monitoring disease both for initial response and relapse. And AL amyloidosis is likely under-recognized and unfortunately underdiagnosed. And looking for the abnormal light chains in the correct context will facilitate accurate diagnosis and disease monitoring. Thank you so much for your attention.
Thank you, Dr. McHale, for that fantastic presentation. Audience, the session is now open for questions. You may ask a question by typing it into the question and answer box located in your GoToWebinar window. Our first question is, what are the best tests to screen for amyloidosis?
Thank you. So the first question is, what test to screen for amyloid? You know, we wouldn't routinely screen everyone for amyloid. I think the entry points for amyloid are usually one of two things. One, that for whatever other reason, someone has had a serum protein electrophoresis and they've been found to have an MGUS. And I suggest that everybody who has an MGUS, amyloid has to at least cross someone's mind. And so hopefully everybody with an MGUS has had a light chain measurement done. That's often the first step. So if I have someone who's got an elevated, in particular, lambda light chain, then my suspicion is higher. But they also need, frankly, good screening history and physical. Does the person have other features that might point towards amyloid? The second angle that people come in where the screening may be of value is if someone has organ dysfunction that, frankly, doesn't make sense otherwise. You know, that woman who's got diastolic dysfunction but is a marathon runner, someone with significant proteinuria, someone with hepatomegaly and an elevated alkaline phosphatase that otherwise there isn't a reason for. And if that's the case, then someone should have a light chain assay done initially, as we saw in that algorithm, and then consider a biopsy, usually from least invasive to most invasive, so starting with a fat aspirate. Because ultimately we need that tissue. But I don't want to start, you know, biopsying everybody. I don't want to become amyloid neurotic. There are a lot of people who have a lot of symptoms that have nothing to do with amyloid. You know, it's such a rare condition, and there are a lot of people who are fatigued. So by no means do we want to recklessly screen people. But the ante is upped when someone has objective evidence, such as I mentioned, the proteinuria, the diastolic dysfunction, and the hepatomegaly.
How do you use serum-free light chains to monitor therapy while on treatment? Do you use an absolute value or percentage or difference between involved and uninvolved light chain? And what values do you use?
Well, that's an excellent question. So I would say there's probably two ways to look at that. Generally speaking, initially, there really has to be an abnormal ratio for you to consider it pathological. And the reason for that is if I just go down, for example, to the dialysis unit today and measure everybody's light chains who have renal dysfunction, and because so many of our patients with plasma cell dyscrasias have renal dysfunction, it's relevant. Many of those patients are going to have a slightly elevated kappa and slightly elevated lambda level, but the overwhelming majority will actually have a normal ratio. So to kind of get the ticket to get in the door, you have to have an abnormal ratio because it's telling us, it's speaking to us of monoclonality. Because in monoclonality, there's always going to be a predominance of either kappa or lambda. So once the ratio is established, if someone has an abnormal ratio, that kind of gets you into the mode of where I'm going to follow this person with their light chains. I find it pragmatically easier to follow the absolute level because of the one that is involved. Now, I'm not saying the uninvolved or the ratio is unimportant. Those can definitely help, especially if something looks odd. But, you know, very often if let's say we're following someone with a lambda predominance, because lambda is in the denominator, just mathematically, it's easier to follow that absolute number because it can be heavily influenced based on what slight changes there might be in the kappa level, or similarly vice versa in the lambda level. So I actually, generally speaking, will follow that absolute level because if the absolute level is high enough, there's still going to be an abnormal ratio. Where the challenge comes is in that patient, let's say, who has renal dysfunction. Yes, I might be following that absolute level like in our patient when she was way up at 600. But once she starts to get down below 20, once she starts to get down below 10, then the ratio becomes more important to me. Because then I expect that in her uninvolved light chain might be a little bit elevated as well because of a renal dysfunction. So in summary, the ratio is really important to dictate monoclonality. Once I start following and monitoring a patient, especially on therapy, I'll primarily follow the absolute number, but then once the numbers get close to each other, the ratio becomes important again.
What is the prognosis for the amyloid patient?
The amyloid patient that we discussed, I guess it partly depends on when you discuss it. So historically, let's say up until 4 or 5 years ago, people who had symptomatic heart failure with AL amyloid, based on what case series you look at, the median overall survival was somewhere between 9 and 12 months. Thankfully now, with more judicious use of stem cell transplant and novel agents, namely the use of bortezomib, we're seeing that a lot longer now. In fact, there's even a small subset of people whom, if we catch them at the exact right time, not only can we do a stem cell transplant, we can actually even do a cardiac transplant. Sometimes that's valid. So it's hard for me to give an exact number. In our experience looking at our database, someone like our woman who's presented, what's critical is to get her through this first period to see if her heart function is going to improve. And if so, her prognosis could well be over 3 years. But if we're never able to get her out of heart failure, then sadly she's still in that prognostic group of about a year.
On the third patient, when the plasma light chain was slightly increased, was any bone marrow biopsy done? If yes, what was the percent of clonal plasma cells?
I'm going to just flip back up to it so people can see. Sorry, you hopefully still see your screen. I'm not trying to invoke any seizures. So this patient that had the slow relapse, if you will, that, as you can see here from the bottom line, their light chain was slowly climbing up. We did not immediately at this point do a bone marrow. I don't always do a bone marrow. I will always do a bone marrow, I should say, when someone is going to start therapy or if we're strongly considering someone to start therapy. Because the challenge here is that light chain, let's say, goes up to 4, 5, 6, 7, 8, 9. If I'm not going to immediately treat the patient, I'm not sure there's anything on that marrow that is going to change what I do. So what if I did the marrow and the plasma cell percentage was even 15 or 20%? That's not what's going to dictate my therapy. It's that change in the light chain, it's that change in the M spike that's going to dictate therapy, along with, of course, any evidence of CRAB. And again, I'm not by any means belittling the checking of a bone marrow, but I would only do that at time of relapse because that's going to help when I'm going to start therapy, because that may help dictate the therapy if I find a high-risk feature, such as, let's say the patient's now acquired a p53 deletion or a translocation 414. That might guide my therapy a little bit more. But just checking the plasma cell number, because we're not continuously checking that, may mislead you to either over or under treat based on that number. Not to mention, of course, that myeloma is a patchy disease. I can do a bone marrow on a patient 2 days in a row, not that I do, and one study will come out at 12%, the next may come out at 25%.
If you have a tissue diagnosis for AL amyloid and patient has proteinuria, do you always suggest a renal biopsy? Does it change therapy?
Great question. Short version, because I know our time is running out. I would not necessarily do a biopsy of the kidney. What more is that kidney biopsy going to tell me? If I know the patient has AL amyloid, I've confirmed tissue somehow, and I have that confirmed, doing a kidney biopsy really is more diagnostic than really prognostic in these patients. So I don't, although it's low risk, I'm not really sure I want to expose the patient to a risk of a kidney biopsy. Now, if there's a question and the nephrologist is thinking, wait a minute, this does not all fit with amyloid, could there be another concomitant glomerular or other disease? Well, then yes, of course. But if it's pretty classic, someone has the classic presentation of AL amyloid, they have protein in their urine, we've confirmed it on fat aspirate, it's clearly AL, whether it's by mass spec or other, they've got a light chain, then I don't necessarily expose them to a kidney biopsy. Similarly, for heart or liver or others, I won't do those biopsies unless there's really something that does not fit the usual pattern.
Is serum uric acid prognostic in AL amyloidosis?
There's been interesting work that's been done out of Rochester. Shaji Kumar has published on this, looking at the serum uric acid as prognostic in myeloma, and there's some early work to think that it may be prognostic in amyloid. I still haven't added it to my profile. We check it, I should say, but I don't list it as a prognostic marker yet because there's still some discrepancies in different work that's been done. I think it may be prognostic in certain forms of amyloid, but right now it's too early for me to conclude that.
Should the free light assay be used to determine the depth of response in patients achieving complete response?
Absolutely. So when we look at complete response, depending on which definition criteria you're using, that is normally going to mean the disappearance of a monoclonal protein and the normalization of the light chain measurements, whether we're using complete response or stringent complete response, depending on which criteria you're using. So yes, I mean, to me that's very important. I'm still concerned. Let's say the M spike is gone. Let's say the aspirin serum protein electrophoresis is negative even with immunofixation, but there's still a predominant kappa or lambda light chain. I'm a little bit concerned about that, and so we've included that in our criteria when we distinguish the nuances of the depth of complete response.
Can removal of free light chain help end organ damage?
Well, absolutely. I mean, that's the ultimate goal. Is that I say to patients, unfortunately, I have nothing in my panoply of therapy that can go into her heart and remove that amyloid, or go into someone's kidney and remove that amyloid. All I can do is shut off the production and hope that the body will heal itself. We use multiple analogies. I say if someone really hates a certain kind of car, not that I'm advocating this, and they want to rid the world of the evil of, I don't know, Volkswagen, but you can't touch one, how would you do it? Well, you'd stop making them. So in this woman with the cardiac involvement, I can't go under hard melted yet, although we have people working across the world to therapies that might be able to do that. All I want to do is shut off that production. And so if I can suppress those light chains from being produced, then they're not going to change their conformation and get deposited as AL amyloid in the organ. So yes, we've been able to show clearly that hematological response is predictive of organ response. So that's where it's predictive and prognostic ultimately. Sometimes the organ is damaged, as we mentioned, permanently, and there may not be significant recovery, but seeing that hematological response becomes critical.
And we have time for one last question, and that question is, what is the role of allotransplant in myeloma?
Wow, I love the fact that that's the last question. Uber short version, I think most of us would agree that this is still an experimental therapy because although there may be a graft versus myeloma effect and in some people may be potentially curative, it is still particularly toxic. I mean, the best case series is still 15% treatment-related mortality. And with the novel agents and approaches that we have now, we have multiple upfront studies showing that 3-year survival rates can be well over 90%. So most of us would believe that if it's not in the context of clinical trial, the people that we would consider at least for allo, and I have to tell you we do very few of them now, would be likely a younger patient with high-risk disease, usually the p53 deletion, and, very importantly, who has already demonstrated that the pace of their disease is quickly. Because there are some people with high-risk disease who actually do very well and live a very long time. So if someone is multiply relapsed, and I don't want to wait until it's the so-called Hail Mary pass, but for most of us, allotransplant is not a usual strategy, but we save it for younger patients, high risk, who are already showing that they're multiply relapsed, that we'll consider them, and hopefully they have a sibling donor.
Thank you very much, Dr. McHale. Audience, a copy of this webcast will be posted on our website in approximately 2 weeks at www.thebindingsite.com. And if you would like to request additional information, please feel free to contact the Binding Site by email at info@thebindingsite.com. To receive CME credits, please complete and return the evaluation form that will be emailed to the participants of this webinar later today. And please allow 4 to 6 weeks for the certificates to be processed and sent to you directly from the CME office. Again, Dr. McHale, thank you very much for this informative and educational webinar. Audience, thank you for your participation. The session will now end.